I think the first thing is obviously this morning when Rebecca presented TROPION-Breast02, and I think the first thing is to get everybody's thoughts about it and compare it. And there's a really nice way that they did this. They compared it to ASCENT-03, back to back. And it's kind of interesting to kind of see where we're going to go with this. So looking at TROPION-Breast02, it was Dato versus investigator's choice of therapy. And they, in this particular trial, had 20% of the patients that they allowed to have less than 12 months to progression. And so of those were metastatic disease. And of those patients, they got kind of an unusual, what I would consider unusual, and I'm going to ask you guys what you think of it, an unusual group of chemos as the control arm. So it was CAPE, eribulin, and carboplatin. What do you think of that?
I'll jump in. I think CAPE is something many of us might consider, even if we don't have a lot of confidence in it in that role. Eribulin is something we also reach to. Carbo by itself is a little bit unusual for these patients who theoretically have probably just progressed off of a taxane, maybe even an anthracycline. These are not unreasonable, but the single agent choices may not reflect what we do in the US entirely.
Yeah. I might have put Gem-Carbo together as an option.
Correct.
Yeah, right. And I don't know the reason. I guess we don't have anybody to answer that. No one's an investigator on this. Was anybody an investigator on this? No.
It was only 3%, 3 to 4% of the
Got
population.
what?
Got carbo.
No, most people got eribulin. I think
Yeah.
40-50% got eribulin.
But it is interesting that they allow for the rapid progressors without a doublet option
Right.
in the physician's chemotherapy arm.
I mean, the standard, I think a lot of us use, I don't know what NCCN is. We've got NCCN people in here. I don't know what the NCCN standard is. So if you have rapid progression, I mean, say within 6 months, I normally would give, SASI, I give SG. Would most people give SG?
Yes.
And you get insurance to pay for it. You consider it like a third-line chemo, right, pretty much?
Although the former approval would be for patients pretreated with chemotherapy, even in the metastatic setting. They had
Correct.
a small sub-analysis showing a benefit in first line,
Right.
but formally, I think, in the trial design, it does make sense to offer, for instance, eribulin. It wouldn't be wrong, and
Right.
I think some patients got eribulin on the trial. So
Right.
I'm not totally, I don't feel totally bad about the choice of expanding to other agents, and CAPE, only 2% of patients got it, so probably
Right,
it didn't impact results.
right,
You have
okay.
to imagine a lot of these patients might have had adjuvant CAPE anyways. So,
Yeah, correct.
Well, that's
Yeah.
it. You're not going to give, if you get
Disease,
adjuvant CAPE, you're not going to
Yeah.
give this. Well, yeah, think about it for a minute. I mean, these are, let's assume they're higher risk. None of them were Keynote 522-ish. Not a single one of them, as far as I know. Were any Keynote
Right.
522? I don't know.
I don't
No, they didn't.
No, I don't
comment
think
on
so.
that. And there's no immunotherapy subgroup. So I'm also assuming that they didn't receive immunotherapy.
So no one got
No,
immunotherapy.
but these are patients that are already otherwise receiving an anthracycline, a taxane,
And
at
CAPE?
this point, and
But-
CAPE.
So
So
about
I think
CAPE?
the eribulin will be certainly my
But
preferred
when you
choice.
look at the subgroups and you see the North American breakout, who probably did get immunotherapy.
Right, well,
given
we'll
the
talk
access,
about that in a
right?
minute. We'll get to
But
that in a
might
second.
influence who got what as well.
But the first question is, so people are okay with the control arm. It was only 20%. And I think, the patients who progressed after 12 months were taxane. Were either nanoparticle paclitaxel or paclitaxel. I think I'm okay with. Are you guys okay with that?
Yeah,
I'm
absolutely.
I'm okay with that part too. I don't think it's a problem. All right, so that part. So
And, I mean, I'm sorry, but.
No, go. Say
also-
what you want. Say please. Keep saying what you want as we go through
this. It's a little slow looking this up. But, the relative benefit wasn't any different between the early progressors and the later progressors.
Right.
So it
Right.
Probably didn't seem to make a big difference, even though I think we all agree that those would not be
No, it would
our
work. Well, we know it
ideal-
works.
Our ideal choices
Yeah.
for that patient population outside of a trial.
right, it's more. I think, is the control arm reasonable? That's the point. Because the control arm PFS is a little. Well, no, the control arm PFS is actually the same, wasn't it? Even
Slightly
despite
lower,
this, the
5 point
control arm
something.
PFS
Yeah.
was the same as Keynote 355. And they made a point of that. Someone made a point of that. Either Anna or Rebecca made a point of that.
Yeah, it was like just a touch lower,
Just a touch lower.
despite the inclusion of the rapid progressors, which is
Yeah.
interesting. But I, one of the things that I wondered is that I think it's a strength in the trial design that this population is included. But I also wondered if it might influence the selection of patients that you would enroll on this trial. I'm not sure how comfortable I would feel enrolling somebody who progressed within 6 months on a trial where they could potentially get single-arm nab-paclitaxel. But I can't wrap my head around how that kind of selection bias may or may not have contributed to the endpoints in the study. I don't think it's a bad thing. I think it's a strength of the design. I just wonder about the selection of patients.
What was the dropout on this? How many people dropped out? Do we know? I don't even know, because that's a good question. Because if you put someone on this trial and they didn't get what you wanted, then you just took them off.
Yeah, exactly.
Well, but it's investigator selected chemo, right? So you can already say, okay, at least I want to do a Rebulin. You can shield that part.
And I guess this was conducted in countries that may have not have access to any ADC. And so for even just having 50% chance of getting ADC is a lot for them.
Right.
And one thing I didn't love is that they didn't break down US, Canada, Europe. I think it's so relevant to know how many patients are from US, from
Because
Canada.
Canada, because it's Eribulin, not Eribulin, whatchamacallit, SG is not available in Canada, right?
Oh, it's not?
I don't think so.
There's limitations in many countries. Even
Not
in
in the
Europe,
first
some
line.
countries allow you first line triple
Right.
negative, some don't.
It's not like the
so
US.
It's important to break
Right.
down.
Yeah.
I agree. So everybody's okay with the trial design, basically, is what I'm hearing. So, and then you look at if you guys have the baseline characteristics on here, I'm okay with this. I mean, again, these are typical. I mean, most of the patients we'll talk about when we compare this to ASCENT-03, what the breakdown is of the patients. I mean, they had 15% of the patients that progressed within 6 months. So that's it. You could be 0 to 12 and still get CAPE or single agent carbo, right, or Eribulin. But you could not get taxane if you progress within 12 months. You weren't allowed to get paclitaxel. So I guess that's a good point. Are you gonna, I guess if you had paclitaxel and it's month 9 and you're trying to think about whether you're gonna enroll someone in this trial, would you be upset if you couldn't choose paclitaxel?
No.
No?
In the clinic, I'm going to use
Use Eribulin probably
Eribulin,
off-label? Yeah, but again, would you use Eribulin? You probably would use sacituzumab.
Yeah, no, if I
If
didn't have an
Saci
ADC,
wasn't available,
yeah.
you would use Eribulin. All right.
Giancarlo,
All right, so this isn't bad.
possibly, right?
Generally.
Yeah, Adam, the other thing I would just point out is that PDL1 status, I'm just seeing here that it was 11%, right, positive in the data arm, 9% in the control arm, and I think that's an interesting question of patients who are PDL1 positive, but for whatever reason are not getting.
They may be medically excluded from getting a
Right.
PD-1. Like
No,
had a
or
heart
no,
disease or
it was
something like
insurance couldn't pay for it.
Yeah.
So there
It
are
was not
areas of the
available in the
world
country.
where, right, there are areas of the world where you get it, but you can't get it.
Yeah.
Even though, they don't believe, even though Keynote 355 is available and it's probably approved by the country,
Right.
probably the financial authority said no.
Yeah. Well, I just bring that up as I think it's a strength of the trial design, that there's some representation. The numbers are too small to look at how that subgroup does, and that's a separate
Actually, it
trial.
turns out they do the same as everybody else.
Yeah.
When
You
you
mean
look
the
at
natural history of patients who are treated with chemotherapy despite PD-L1 positivity?
Yeah.
Yeah, agreed.
Yeah.
Well, the other benefit is also that they included patients with brain metastases, right? So
Yeah.
as long as they were stable, so
Right.
they were not
Right.
excluded, which is important. Right?
No,
They
I
don't
agree.
have-
No, I agree.
Mhm.
And so then, go ahead. what were you
I
gonna
was
say?
just going to say, I think if you look at the enrollments, back of the envelope calculations, again, we don't have the breakout. I'm guessing 40-ish patients in each arm are from the United States. That's my guess.
Yeah, that's not a huge number.
It's not a huge number.
Yeah. So that can't be really what's driving what's going on.
No.
I would say. I would
Yeah.
agree.
Does de novo 30% ring true to all of you?
Well, not
Yeah,
anymore.
BC?
I think it used to be.
Yeah.
Now it's probably 40 to
Again,
50.
in the
40 to
US,
50.
yeah.
Given the fact
I
that
think
Keynote
it's
522,
regional.
it's going to be a lot
Yeah.
higher.
It must be regional.
Yeah.
Yeah.
So I don't see that number as too far off,
Yeah.
right?
And-
Yeah.
You think 30 is good?
And I think
Like 30?
Ascent had the same number,
Yeah.
had same percentage.
Yeah, which is
Suggested.
right. But I mean, nowadays, so that wouldn't be the case, right?
It'd be
In
higher.
today's environment,
I would imagine.
it'd be more
you
de
know,
novo.
I think
yeah.
you're
Huh?
maybe putting a little too much weight on the value of
chemo.
pembrolizumab, but.
For, 67% PCR rate or something like that.
Yeah.
You know?
Yeah, true.
Yeah, yeah.
But they still relapse.
And this is not a problem specific to this trial, but I just have to point out, in a disease that is predominant in underrepresented minorities, for African Americans in each arm, it's really
That's how I did the math to figure out how many US enrollments
Ah.
are.
Yeah, it's just, it's very
4%.
disappointing.
4%,
right?
yeah.
4% is very disappointing.
Do you
but
think that's
a
going
lot.
to skew results?
Well, I wonder, because we know that there is some biological differences in terms of how the disease behaves in subgroups that are underrepresented. So I don't think it's a problem specific to this trial, but I think generally we need to understand the disease response specifically in those populations.
And toxicity differences. I mean,
Toxicity
we've seen
differences.
neuropathy for sure.
And even neutropenia if you have
Yeah.
Duffy antigen loss.
Good point.
Yeah.
Yeah.
It is interesting that the top choice of chemo was nab-paclitaxel, which is usually preferred, I feel, in Asia more than in the West. I don't know, I don't usually...
In Europe, they use a lot of it with,
I guess also in Europe, yeah, but less in
there's a
in
lot
the
of
US.
atezo or Braxane in Europe.
Right.
Right, which they can't be in the US. Yeah.
So Atiso is still available here for metastatic? For
Not in the US.
No,
it's
in
Europe.
But he said here.
Here.
You know, here, that's right, we are in Europe. We're not all American, we're in Europe. That's right, that's true, it's a good point. I think it is, and I think people do use it. I think our European colleagues definitely use it, it's got the EMA approval.
I wonder if it was provided. I mean, I don't love all the steroids with Taxol, so if the trial was providing it, I would choose nab-paclitaxel.
The trial was providing
They
it,
provided
yes.
it.
Yes.
Yeah.
I
It was
bet.
a decision, and that's why the majority of people gravitated towards
Yeah.
nab-paclitaxel, which kind of makes sense, right?
Makes
Less
sense.
toxicity.
If you could get it, I mean, it's
Yeah.
much easier to use. Do you guys use nab-paclitaxel in your practice?
When it's approved.
When there's an allergic reaction to
Only when
Taxol.
there's an allergic reaction?
You need to
You won't get it covered otherwise.
Yeah.
I get it covered.
Oh,
I use it all the time, it's great.
Wow.
It's like a 20-minute infusion that people
Yeah.
walk out and
Yeah.
get done. Yeah, it's really very few side effects. All right, anyway, let's keep moving in the interest of time. So again, the PFS by blinded independent review was 10.8 versus 5.6, which is pretty good. I mean, its hazard ratio is 0.57. I mean, it's clearly, efficacious. I mean, that impresses everybody.
Absolutely.
It's
Yeah.
standard of
Outstanding.
care,
Yeah.
practice
Yeah.
changing.
Yes.
It's
Everybody
outstanding.
agrees with that?
Yes.
Yes.
Very early separation, yeah. It's-
Yeah, everybody
Yeah.
agrees with that. I don't
And
think
like the
anybody's
control arm
wrong.
performed as you would have expected based on Keynote 355, so it's really consistent.
Yeah, that's the
Data
thing. You
doubled
like
that.
I mean, it's 5.6 months, so that's what Keynote
I
355
believe
is,
it's, yeah,
about
what you had in
5.5, 6
PD-L1
months.
negative,
Yeah,
and it's
yes, I agree
great
with that.
benefit.
I agree. And that's, we're not talking about that. So then we get to the OS benefit, and there clearly is an OS benefit here, and the hazard ratio is 0.79, and it's about 5 months. So it's 18 versus 23, and 18 is right. 18 is Keynote 355, is it not?
Correct.
If I'm not mistaken?
In the ballpark.
Yeah. In the chemo-only arm of Keynote 355, I
Yes,
think it's,
yeah. Chemo
because
only,
Keynote,
yes.
it looks like Keynote, because Keynote was about
Exactly.
24 versus 18.
Looks like
if
the
I'm not
benefit of
mistaken.
Pembro somewhat, but,
Yeah, it looks like Pembro, basically.
but in PD-L1
Yeah.
positive.
Right,
Yeah.
exactly. Okay, so I'm cool with that. And everybody's happy with this, and it separates at the right time. It's not a fluke, and the curves are not coming back together.
Right.
So everybody's happy with
When they
that.
allocated, inside joke, they allocated the P value appropriately.
Yes, they did. Well, no, they actually had a little thing there, how much they, I don't know, I'm not gonna get into
Yeah,
that.
no,
We're
just-
being recorded, so I don't want the
This part's
biostatisticians to hear my opinions
This
of that.
part's getting edited out. don't
Right, that's
worry.
where I was thinking it. All right, so that's cool. So everybody's happy with this, and I think that, the OS benefit is not surprising. Then they go through all of these subgroup analyses in here, and one thing that someone did point out, I don't know who pointed this out, I don't know if it was Anna today pointing it out or not, is that the way they broke it down, above and below 65, and in the triple negative, wouldn't you want to know how the young patients do, like the 50s, the 40s? Wouldn't it be nice to see that at some point?
Yeah, especially when you see that the over 65 subgroup is very tiny. So you really want a breakdown, those under 65 to
Yeah,
under
like maybe have
50.
another strata, maybe under 50 or something like that.
It seems so that most trials are reporting, they're
Yeah.
doing their
Yeah.
forest
All
plots
the
at
DB
65 is
delta
the
trials.
It's the
cut
standard, I know,
threshold, yeah.
probably the FDA requirement for reporting, who knows, for registrational trial. But everything else is good. And again, we talk about the US, Canada, Europe PFS. With the PFS still, the PFS was appropriate. And I think when we get into OS in a minute by subgroup, we're gonna really talk about this. The PFS was appropriate, right? I mean, it's all looking roughly the same. It's all in that band around 0.5, 0.6, 0.7. So there really was no subgroup that did not benefit in PFS in this, not surprisingly.
I think the wide confidence intervals is just small.
Small
numbers.
Yeah, it's
Right.
small. It's like 30 patients per arm. I mean, with a high CPS of 10, I don't think I could make too much of that.
Right.
Right, it's just too wide. So then we look at the OS, and this is where it gets a little bit interesting. So everybody seemed to benefit with the exception of two groups. The first group was, and again, if you believe this, and multiple comparisons, by chance it could be this. They're small groups, but actually the US, Canada, Europe is not that small. It's 120 per arm, and there's no benefit, actually, in OS in that group.
And
And there's also no benefit in the 0 to 12.
well, for the access to other therapies in those countries is very different.
Is that what most people think? I mean,
It's
the
my
fact, because this did not,
Subsequent ADC, right?
Yeah.
did they talk about crossover? Did they?
No,
do
they
this?
didn't allow crossover.
But did they talk about what the subsequent therapy
Yeah,
was?
they did.
Yeah.
Is that in the
it
slides?
says
I have to take a look
They
at it.
grouped all the ADCs together and said this
About a
number
third,
patients-
a third
yeah,
of
third
them.
of them got
Yeah.
ADC.
Got ADC.
But I can guarantee you that third is shifted to
Right.
those
The
countries.
US,
Yeah.
yeah.
That's for
Yeah,
sure.
I'm just seeing that, so it says 14% in the intervention arm went on to get another TROP2-directed ADC, presumably SASE, and then
Right.
30% of the chemo arm went
There
on
was
to
a
get.
single patient, somebody told me this, got sacituzumab. A
Oh,
single
interesting.
patient, so it was all
On
SASE.
trial?
Yeah,
SAC-TMT on trial?
After study, yeah, after,
Yeah.
on the,
Possible.
that
On their
enrolled.
SAC-TMT
Yeah.
trial,
Okay.
right, okay.
But it was predominantly SASE.
Oh, no, there were Asian enrollments, it could have been.
So
it could have
SAC-TMT
just
is
been
approved, well, that's only China.
China, yeah.
So was this China? Was this trial done in
I
China?
don't know, I don't know.
I don't
It says
even know.
Asia, I don't know.
Asia,
Yeah.
could include China, all right.
Yeah.
So that to me is a, I don't know, but, you know, is that gonna be that big a deal?
I think the question is 30% in the control arm enough of a crossover to skew the OS results specifically in the US, Canada, I guess US population specifically?
But it's 30% overall, so in
Right.
the US, it's probably higher than
It's
that.
probably predominantly.
It's probably like
US.
predominantly.
I mean, to me, it's
Yes.
more a philosophical thing, because when you look at the sacituzumab Bacento 3 trial, we're probably not gonna see an OS signal,
Yeah.
and it's probably for that reason.
And it's-
Only 6% US patients, I think is relevant when you're looking for an FDA approval. I think having more data would be beneficial to just consolidate and confirm the benefit.
Yeah.
And having a minimum cap of US patients, I think would be a lot. Because, for instance, we're not approving drugs based on China-only studies.
Right.
And I realize Europe has got a more similar practice to US, but still 6% US, I think is a weakness of the trial. That remains a super solid trial with amazing results, but it has some weaknesses, and this is one of them, I think.
Yeah. Is anybody concerned about the lack of benefit in the 0 to 12s in terms of OS? That bother you, or is it just, it's just too small?
I think it's
What do
too
you
Too
think?
small,
Yeah.
and in PFS, you don't see that.
Right, you don't see
So-
PFS, you see a benefit, it's
Right,
good,
so
right?
that's why it's
Yeah.
hard to.
Yeah, it makes no, why, that doesn't make sense, right? You
Yeah.
get a PFS benefit, not OS. I don't
It's a
understand
fluke.
that. That makes
Well,
no
we
sense
see,
to me.
I mean, we see PFS benefit without OS benefit in this
Yeah.
disease all the time. though.
What we
Yeah,
don't know
yeah.
in this trial is how many people went on to the second line, do we?
Yeah.
We don't know that.
We do.
Is it later
Well, I
on?
mean, sorry, yeah, I don't know if we know how many people went on the second line. I thought you were saying how many people.
How many
Came
people
off
went to
trial.
second line therapy? Was that presented?
I think
Did
it
Rebecca
wasn't
present
on
it or
us.
not?
I think
Yeah,
it
it's
was,
anonymous.
yeah,
It
yeah,
Oh,
it
was
was
it presented?
presented,
Okay.
I
How
thought.
many went on to second line?
Wasn't it like 7? It was
I
don't know
high,
if
I thought
AZ
it was
knows that or
70%, wasn't it?
I don't-
Again, because it's
I don't
such new
recall.
data, it's
Not
only
in-
2
She
weeks
didn't
old.
have.
Oh, she
It's
didn't
kind of
have it?
unfair
There
to
was
ask them
some.
for that.
Let's-
She, I'll pull it up.
I thought it was high for some
She
reason.
struggled with trying to get all the numbers, because again,
It's so fresh.
It's
She
two
probably
weeks.
didn't have everything.
Well, no, because that would argue, you know,
72% had subsequent therapy at data cutoff.
Yeah,
that
that's-
was in.
Tropiano too, yeah.
That's,
Tropiano
I
too,
think
70%.
That's pretty
Probably
high.
discussed on behalf.
I mean, my question would be
Anna
specifically in
was-
those
Ah, I
rapid
see, I see.
progressors,
That's
why.
what percent of the rapid progressors
Progressors, yeah.
went on to get second line therapy?
I mean, they
Because
have such
that would
bad
be a win.
biology, so I mean, I think they were gonna crash and burn, and so that
Right, well, no,
explains
that's
those-
a,
yeah.
well, that's the
Yeah.
point. They were gonna crash and burn.
No, but Miriam, that's what I mean. Like, I totally agree. Those patients do so poorly, but I think a win would be if we see a clinically meaningful, however we would define it, percentage of patients in that subgroup who went on to get second
Which is
line
kind of
therapy.
what we were doing anyway. We're giving them a TROP2 ADC in the US.
Yeah.
We were doing that anyway for these patients.
Yeah.
But in some ways, these patients, I mean, we're calling it a second therapy, but they just finished their first therapy
Yeah.
before they had metastatic
Yeah,
disease,
it's
right?
like
So
there's-
this is like their fourth line.
Yeah.
They're
Yeah.
getting AC, a taxane, this
Yeah.
drug,
Right.
and then another drug. Like
Yes.
that's
Yeah.
Right.
how often do we get to 4 therapies in triple negative
Yeah.
breast
Mhm.
cancer metastatic, right?
Yeah.
It's not
And when we
common.
get to 4 therapies, they've already declared themselves better biology.
Correct.
And they
Correct.
probably are
Correct.
brain mets at that point.
Yeah.
Yeah, exactly. All right, good. All right, so let's see what else we want to talk about in this. And then we get to the safety. And again, when we start comparing this, I mean, no death, which is great. The ILD rate was on the low end. Let me see if I can get to the ILD. I don't know if we have the ILD here. Let's take a
There was
look.
like a toxicity of interest slide.
So basically, it looks like there's a little bit more dose interruption and reduction, not a ton more with Dato versus the standard of care chemo, not a ton. And again, if you consider the vast majority of standard care chemo was paclitaxel and particle paclitaxel, you know, you're not probably going to dose reduce that a lot.
Eribulin?
The
But really, I want to get into
11
the,
or something.
Yeah.
The discontinuation rate was lower. I think that's a huge
It
win
was.
for TNBC.
that seems to be that seems to be a class thing, because we're going to see that in ASCENT 03 also.
Yeah.
Yeah,
Mhm.
the discontinuation rate is lower. Now, is that kind of almost informative censoring? You know, you kind of know what you're on, right? So maybe you're saying, well, I got the stuff I can't get, so I'm gonna, I have
I'll
more,
tough it up and then.
me and the
I
doc
could
really
see
want to
that,
keep me on the
yeah.
drug and not
Right.
discontinue me because I can't, I'll just go to standard care chemo and I don't really want to do that. I don't
Yeah.
know, I'm just.
No, that was my initial
That's
thought.
fair,
was-
yeah.
You think that
because
people just
that's
wanted
the-
to stay on it?
Well, and
Yeah.
also just, I mean, we're all card-carrying medical oncologists. These are not things we can't manage, so we're going to work with our patients and help them through as much as
Yeah.
we can.
Yeah.
We'll fight for it, right?
Mhm.
Yeah, all right, so let's go through the special interest, because this is really where everything is going to be different. So stomatitis, 8% grade 3. That was probably the biggest difference. And then the keratitis, which is again, I don't know what what is grade 3 keratitis? What is that?
It sounds bad.
Well, what is grade 3? I don't know how to grade keratitis.
I don't know if it's already
So,
ulcerative.
Grade 1 is
Like,
asymptomatic
ulcerative
and
keratitis
only
is
seen by
grade
the ophthalmologist or
Okay,
optometrist.
fine.
Grade 2 is symptomatic dry eye. I think grade 3 is literally like fissures and cracks and kind of bad stuff.
And you can't see.
Well,
Is
I
it
think
visual changes
I don't know.
involved in
I don't
it
know
or
where
not?
visual changes
I don't
comes
think
in
it's
for the
loss of
ocular.
vision.
Yeah.
I think it's surface events.
Surface events,
yeah,
okay.
Yeah.
So, and the question is, the treatment is steroid eye drops, is that correct?
Right.
Is that what
Yeah.
they gave in the
That's
trial?
what they gave.
Did
yeah.
patients get prophylactic
I don't know.
mouthwash and dry
Did they?
and
They
eye
did on
drops?
this study.
So
Yeah.
here,
It
They
was
had to definitely, I
recommended.
remember, because we
Yeah.
tried putting people on this, I remember they had to get the steroid mouthwash,
Yeah.
right? You had to
Yeah.
take that.
And you had a baseline and
And-
serial
and
visits with
4
an
drops.
ophthalmologist as
Yeah.
well.
Right.
So was it mandated, the steroid mouthwash on this trial? Because usually it is not on
Not on
the
their
It was
first trial,
recommended.
but in this one it
I
was.
thought
Yeah.
it was
Yeah, this one was
mandated.
mandated.
I
I
mean,
mean, Rebecca answered
it was not
She said
mandated.
they
It was not
couldn't
mandated.
track it, but
They
it
couldn't
was
track the
but
use of it, whether
yes.
people were using it or
Yeah.
not?
Yeah,
Yeah.
I think it's important to point out that in the real world we see less stomatitis because we use mouthwash. But in all of the trials, I believe, it's not mandated.
Yeah. And it's not available in every country.
Right,
Mhm.
right. But it's a pity. I still feel it should be mandated. We know that this drug has got stomatitis. I wish it was mandated, but I realize there must be some
And
challenges.
it's not just
So-
about mandating its frequency too, right? Because technically you have to use it
3 to
per
4
day.
times a day. Yeah.
If
So
you use it
people,
once
right,
a day,
3 times a day is a
something-
lot for somebody to use.
Yeah.
But some people have said this kind of goes away with dose reduction. Has that been,
That's been my anecdotal experience. For
so anecdotally,
patients.
does it kind of get better with dose reduction?
Yeah, I
Kind of
mean,
like the diarrhea with SG gets better with dose
Yeah,
reduction?
yeah. I thought that the AE profile was really well manageable.
So that's the
Very
bottom
tolerable.
line. I mean, the A profile is reasonable, even though it's unusual. People have to get used to it.
Yeah.
It's
It's
managed.
unusual. I think the people that have to get used to it is us. I mean, I'm not used to seeing patients that I literally gave a patient a tissue because I thought I made her cry, and she looks at me and she's like, "No, my eyes are always like this."
Yeah.
And I said, "That looks bothersome. Is that bothersome?" She, no, it's not bothersome.
But you
So
know,
I-
we maybe don't appreciate how much our regular chemotherapy drugs cause dry eye. in
Yeah.
We really
patients
don't.
as well.
And that's the
Yeah.
thing. We're not looking for
We
it.
just
Yeah.
expect people to live
We
with
dry
it
everything
and,
out.
and deal with it. Yeah.
Yeah.
Yeah, we dry
Right.
everything out.
Are you
The
using ice when you're doing the infusion or not?
Like the mouth in the mouth. Yes. Yeah.
So you have people chew ice? during
Yeah,
it?
as
Sort of
well.
hold
Does
it
it
in the
help?
mouth.
But the
Yes.
drug circulates for so long. I don't know how just chewing on cryotherapy in clinic is
I don't
gonna
know if it
affect,
helps.
but yeah.
But it's a low toxicity intervention.
Yeah, it sure is.
It is low
It's
toxicity.
ice, right?
It's low toxicity and reasonable.
Yeah.
All right, so let's keep going here. So then the secondary endpoints, I mean, the response rate is high. I mean, 62% versus about 30% with standard care chemo. And 30% is about right for standard care chemo in this setting, would you say? In terms of response rate?
Yeah.
If
Do
you
we care,
include,
first of all, do we care about response rate?
Yes.
In
We
this
do.
disease, I think
Yes,
we
you
do.
in this
We
setting
do?
we do.
Yeah. In this disease.
So we care about response rate.
Yeah.
Okay, that's cool. That's number one. So number two, and the response rate is substantial. I mean, it's 62%,
That's
which is pretty
2/3.
high.
Complete response is so much higher, 9 versus 2.5, which
Yeah.
is great.
That's like
Progressive disease is
That's
half.
like HER2 numbers, right? Like
Right.
It's almost
CR.
HER2 numbers, so it kind of is approaching that. That is
Yeah,
correct.
yeah.
All
And
right.
it's associated with long duration.
Right, it's
Right.
12 versus 7 months. I mean,
So I
that's,
think those two.
so, so when ASCENT came out, when ASCENT 4 came out first, everyone was going around saying, oh, it's because you have prolonged duration of response. And we'll get to ASCENT 3 in a minute. You have prolonged duration of response because you've exposed the immune system, and so it's an immune thing. But it doesn't seem to be an immune thing because it happens in the non-immune without pembro, right? What explains the long duration of response? Just retention of the drug? What explains the long duration of response here?
Well,
I think
compared to
more than chemo.
nab-paclitaxel, I assume you cannot give nab-paclitaxel for a year, but
And
you
part
can
of it is-
give T-DXd for a year.
Yeah,
and that
part of it is
matters.
tolerability, I do
Yeah.
think. You
You
know,
think
they
it's
can stay
tolerability?
on therapy.
You can stay on therapy longer, that's
Yeah.
probably what people think.
I think so. I think it's all mostly
Fair enough.
adverse
And again, they'll
events.
show like the dose intensity stuff later on.
But I don't think that the response, I don't think we can understate how, at least in my mind, how impressive the response is here. I mean, these are the patients, we're fortunate in breast cancer to not have to deal with too much ascites and all these other kind of complications of cancer growth, but if we do, it's typically in this disease, right?
Right.
And so I'm thinking of all of my patients with TNBC who've, had to have, 10 coughs and pleural catheters and things like that, and based on this data, I would definitely want to treat them with T-DXd.
Yeah.
If you're worried about a patient being near a visceral crisis, you're probably going to reach for this agent.
Right. So this is it. So I mean, that's the bottom line. So I think what is everybody's takeaway from this particular study? That it's now standard of care? A standard
It's
of care.
a standard.
It's interesting they said the standard.
Of course they
They
had.
said the. I don't know if I would have said the. I don't know if that was caught. I would have said a. If I was an investigator looking at these slides, if I was Rebecca, I would say, you should probably say a.
Yep.
Even though it probably, well, we'll talk about that in a minute. Let's talk about ASCENT-03 and then we'll kind of get back to that. All right, so that's that. So let's go to ASCENT-03 for a minute. And we all agree that this definitely is something that's practice changing. So now we do ASCENT-03, kind of pull it up here. All right,
I
so
guess I have to ask, is there a standard of care first-line therapy in triple-negative?
no,
there
there is not
isn't.
a standard
Yeah,
care,
That's the
right?
point.
so maybe that's why they could say the new standard of care.
Or one of the,
Yeah.
I don't know.
Well, I mean, NCCN right now just lists all the traditional
Yeah,
chemo.
there is
Yeah, it's
no
going to be interesting
one.
what NCCN does. You guys are all NCCN in this room, right, except me?
I'm not either.
You're
not.
either, right? You
Just
guys
a-
are all NCCN.
Just
What do you mean?
disability.
I'm not on the panel.
But you're an NCCN institution?
Yes.
Yes,
Yeah.
oh, yes.
Yeah. So, all right, fair enough. All right, so then let's get to ASCENT-03. Again, a little bit different. So they did not allow less than 6 months. So if you had progression within 6 months, and I don't know why they did that. I'm assuming because in the US, we could give it. A lot of us gave it in less than 6 months. I don't know, why do you think they did that? Why do you think they allowed
I think
immediate
it would have been
progressors?
weighted that way in the US, I think, if they allowed for it.
Yeah.
I do get some trouble trying to get SG in the first line as standard of care.
For someone who's progressed that quickly?
So it's, when I mean some trouble, I mean sometimes there is that added paperwork of the
Yeah,
back and
it's
forth.
right.
Prior auth.
Prior auth,
auth,
yeah.
exactly. And so I think if this trial allowed for it, I probably would have said, let's just go on the trial. Yeah, so I think they were probably thinking in terms of this would be weighted towards that population. Now they could have, built in a cap like TB02 did.
Right, there was no cap, but we'll get to that in a minute. We'll talk about that in a second. But any other major differences? Obviously, they only allowed 2 chemos.
The choice of chemo, right? They were
Yeah.
doing that
Choice
with
of
the
chemo was a
carbogen.
big difference, so
Yes.
it's
There is no
NAP.
Rivulin. So
Right.
Well, and you see, when you look at the data later, you see the response rates, the differences in response rates between the investigational arm and the standard of care arm aren't as dramatic as what you saw in the other trial.
Right.
Probably because so many patients got double chemotherapy.
I think a lot of people got
Yeah.
the doublet
Yeah.
who got, ACT, because again, this is in the pre-keynote 522 era.
Right.
So
Yeah.
most people got dose-dense ACT, it's pretty much the standard of care,
Mhm.
right, for this in the neoadjuvant setting.
And maybe
probably.
CAPE after.
Yeah.
Yeah, they
And
got CAPE
CAPE.
after.
Yeah.
Actually, I would guess, and we'll probably know this at some point, again, this is as that was developing, right? So it was before everybody, I think it was before NCCN even allowed it or put it in the guidelines. I don't know when NCCN put CAPE in the guidelines. How long ago did they do that?
It's been,
That's been a
I
while.
feel like
5
6
ago.
years.
So it has been, so
2019.
maybe it was
2019.
standard of care, maybe
Yeah,
it
like it was
was.
standard of care.
I don't know.
Yeah.
But anyway, I think most
Well,
people.
I mean, it says there's actually 20% of patients got CAPE.
Got
in
CAPE,
early
yeah.
disease
Yeah,
setting.
fair enough.
Though I will say, I think there are many more similarities than differences between these 2 trials, which rarely happens when you compare trials.
Well, they are
So
pretty similar,
I think
I would agree.
so, no, it's trivial, but just I feel it's rare that you can you can compare 2 phase 3 trials so easily. We should never do that, but in this case, probably it's a
Probably
bit more
could. No,
allowed
I
than
agree.
other cases.
I think
probably, yeah.
Agreed, but caveat is that OS here is a secondary endpoint, right?
Yeah,
Not a
right.
Yeah,
co-
and the crossover, probably that's
The
the
crossover,
major,
I think,
the
is the
major
big one, and
difference.
that's where, I mean, let's hold on the crossover question for a minute.
And the
before we get
follow-up
to
is
it.
different too.
True.
How's the
Follow-up's a lot longer.
Yeah.
And,
Yeah.
Yeah, because they're looking at survival.
Yeah.
I was always
just- I mean, they
wondering where
just
this
have
trial
had-
was.
They're reporting it.
You know, I thought the reason they didn't report this, because it wasn't gonna work. Even though we saw Begonia, you know, and Begonia is 82% response rate when you gave it with, in first-line therapy, when you gave this with Pembro. And so I was like, wow, this is great, it's gonna work great in the first line, and then we kept waiting.
Mhm.
You know, it's like, well, ASCO, where is it? San Antonio, where is it? And now I think I know why they were waiting for the OS events, because it was a co-primary endpoint. All right, anyway, so looking at the demographics of this trial, I mean, pretty much, you'd say it's the same by and large, 30% de novo, 20% recurrent within 6 to 12 months, and about half were after 12 months, I think it's about half were after 12 months
In the other trial as well.
in
Yeah,
TB02.
It's almost identical because it's 34% de novo.
30%.
Yeah,
The other one was
difference in this-
34% de novo,
Yeah.
20% between 0 and 12, and 46.
Yeah, so it's pretty
Right.
close.
Right,
It's
so
pretty
almost
close.
spot on.
They had much less positives, PD-L positives.
Yeah, that was another
Yeah.
big difference. But again, what does that mean, you know,
There
in
is
the
a,
metastatic setting?
there is a 1-month difference in the control arm, progression-free survival, like that was like 5 point.
Well, we're gonna get to that in a minute. So let's talk about PFS. So the PFS is better, I mean, it's 9.7 versus what, 10.8, I think, if you wanna really compare,
Correct,
do
in the
cross
other one.
comparison.
Yeah.
But the control arm did better
Mm.
in the chemo.
Mhm.
Do we think that's because of the doublet, the Gem-Carbo doublet?
Doublet and less of those
No,
0
yeah,
to
they-
And less
they
of
were
the
not
rapid
as
progression.
effective,
And less,
right?
and
That's a big
also
one.
the less
Yeah.
6 month.
That's a big
also.
one.
That's right.
Yeah, so those two is the
But
reason.
that's only, still, that's 15% of the patients. I know it could influence that number, but that's
Okay.
not.
I mean, the hazard ratios are pretty close.
Yeah, I was
to
going
each
to say,
other.
that what's important is the hazard ratio.
Right, and
because
they're
the
pretty much the
population's going to be a little
same.
different, and the median, you know, if you look at the curves, if you look at the Kaplan-Meier curve in ASCENT, you know, it's not very regular, and so you look where the median is, it's just, you know, it's probably not proportional hazards, and I think the hazard ratio is probably the best, at least that's the way I look at trials like this.
Yeah, and I think they're pretty much, would you say 50.57 and 0.62 are pretty close to each other?
Yeah.
Yeah.
Within the realm?
Yeah, well,
I would agree.
the
I mean, I think
CIs
that in terms of
crossed.
efficacy there, I think it's the same.
Mhm.
All right, so we did that. Most subgroups benefit except for the old people, as well as people on Gem-Carbo. Do you think that's real? Again, getting to this whole subgroup analysis stuff. The people on Gem-Carbo, the reason it didn't do better is that the control arm did really well, 8.1 month PFS in the
Yeah.
Carbo-Gem
Mhm.
control. So that's kind of, that high? That seems high to me.
It does seem
8.1.
high.
8.1 seems kind of high.
Yeah, especially for the population for whom you'd select Gem-Carbo.
Right.
Correct.
Seems-
They might
Seems
be
a little on
BRCA
the high side.
patients. Do we
Oh,
know
good point.
anything about BRCA
I
status?
think they
No, they
reported
did
that
not.
yet.
No one
Yeah.
reported that yet. I'm sure they
It's gonna
will
be
at
small.
something. And then the response,
But on that
5%.
point, though, I think that would be really fascinating, just
Right.
knowing what the topoisomerase
Yeah, yeah.
inhibitors are doing in that population. I wouldn't be surprised if the difference between those curves for those patients would be dramatic
yeah.
in both trials.
Yeah.
Mhm.
Yeah. So the response is interesting. Again, at endpoint, we kind of fell out of favor, but the duration of response is the same between both trials, but the response rate in this is less, but more in the control arm. So it's double. The control arm response rate was, what, 22% or something?
30.
30, and this is 46
Yeah.
in the control, probably because of the gem, probably because of the doublet,
Yeah.
I'm
Yeah.
guessing. But the experimental response rate is definitely lower. Do you think that's real between the two or not? Or it's
I
just,
think we've never
nature
seen
of the
over
trial.
50%.
we're not supposed to be
response
doing
rate.
cross-trial comparison, but we are. So what do you think?
If you take all of the SASI trials, I don't think we've ever seen response rates in the 50 or 60%. I can only remember 30 to 40%. So they're still looking nice, but consistent with what we know.
Okay.
Yeah.
I mean, I think several of us, I think we talked about this earlier with the Datto study. I mean, it's the response rate that really at least struck me when I saw
So
that.
it's 62 versus 50.
On that 9% CR, right? That's
And I'll
Yeah.
take a slightly different view, which is the primary response of progressive disease was really just 5% in this study. That means a lot of patients, quote, are theoretically benefiting.
Right.
right? And then it was similarly good in the other study as
Yeah.
well, I'm sure. So,
Yeah.
yeah.
Okay.
I mean, their complete response, 7%.
7% was
Is
still pretty
also
high.
on
Yeah.
Delphin, so.
Yeah, not bad.
So again, this is what I think is going to be the mystery of this particular trial. Okay.
Yeah.
So the
But it's
bi-
also, just
Go ahead,
not to
before you go.
harp on that point, but it's also sort of, for those rapid relapsers who were not included in ASCENT-03. So now you have TB02 where they were included, and you have that response rate. I mean, I think
Right.
it really carves out what we're going to do for that population.
right. So a really rapid progressor.
Yeah.
You're looking for an ADC. You probably are going to choose data.
Right.
Sounds like. Is that what I'm hearing
Yes.
from
Yes.
everybody?
But
I
also,
would
I
say
would
that's
say
probably
for
right.
our high burden disease, I'm sort of swayed towards data as well.
Because of the response rate.
Because of
yeah.
the response rate.
Yeah.
But also for any other patients, I feel like data is preferable compared to SASI based on the data we have. But we
Right.
may get at that at the end, but
Right.
when you compare them, I feel data is just to be
Plus
preferred.
the schedule.
The schedule.
It's scheduled. No, there's a lot of
Key,
reasons to
yeah.
use it. No, I would agree. I think I'm agreeing.
There were no
here.
deaths.
But what I don't quite understand
Spoiler
here,
alert.
That's
well, I mean, I get, so, you've got the survival in PFS2, all right? And the PFS2 is better with a hazard ratio of 0.7. That's statistically significant. But OS is exactly the same, at 0.98 hazard ratio. I wonder if they could project that out and see if there's going to be enough events to actually show a difference at some point. I don't know. But let's assume there's not. Does that make sense? Does the PFS2 make sense with the hazard ratio like this? That's the thing I don't understand with the survival. If your PFS2 is better,
Yeah, eventually you should have a survival advantage.
You should.
right, or the PFS2 really should not be better. It
Right.
should be the same
Yeah.
because you're rescuing people on the back end by giving them SG.
But again, it says not yet mature, but I would even say hardly mature, right? Because in the other trial, you had 2 years of follow-up. You only have
Right, it's not enough follow-up here.
You just,
So you
yeah.
can't really
So we can
compare them. It's a
speculate. but
secondary
just-
endpoint, it's
yeah,
all
It's just
speculation.
hard. Yeah.
It's hard. And it's hard to know. I mean, I think that, again, the marketing people from AZ are here.
Yeah.
And I don't know if that should be something that you should push too hard.
Mhm.
AZ
I don't know,
should
would you
push
push, would AZ, should AZ push
AZ
it?
should push it.
But
They
the
got it.
survival.
Should
Oh,
they
the
push the
survival,
survival?
Yeah.
Well, I mean, Trodelvy has pushed survival in ER positive, right?
Yeah.
They have,
Yeah,
right,
yeah.
so, it's
So
good,
I-
I agree with you.
I think
No,
I
but-
think it's fair, yeah.
Yeah.
And you clearly, it's not only about survival, it's about responses, it's about
It's the
reliability,
whole
schedule.
package,
Yeah.
it's the whole package.
Well,
I
and
get
certainly
it.
the tables are turned in the ER positive setting.
Yes, they are.
Yeah.
The tables are
Yeah.
turned.
And in general, it's the first phase 3 trial that shows OS with this drug in breast
Yeah.
oncology.
Yeah.
So
Yeah.
I think
Right.
it's important.
We've had
It's
a
relevant.
lot of swings and misses in this space with
Mhm.
other drugs. It's
Oh, yeah,
just,
tons.
Yeah.
Tons.
Mhm.
Okay, I agree. All right, and then again, the safety is not surprising. I think the big thing that happened here, it's diarrhea and
Neutropenia.
neutropenia. And I think that, they had 7 deaths from what sounds like tiflitis. I think that's what it was. They didn't say it,
It's
but
going to scare the community oncologists.
it's going to
I
scare the crap out of them. I agree with you.
I
But
mean,
it's
I think
tiflitis.
they
I'm
have
pretty-
not quite acquired the habit of primary prophylaxis because that was a later change to the label.
Yeah.
So I think it's going to take a lot of education and dissemination.
Yeah.
Although, I mean, they're used to using SASI.
Yeah.
I mean, they've been using SASI in later line patients who are going to have more problems.
Yeah.
Right.
Yeah.
So I don't know,
But
but I think
a
that
global
now they,
trial.
but now they have yeah,
Yeah.
but now they have a comparison that doesn't have
Yeah.
those.
Yeah.
I mean, they have another, there's another option that doesn't have that.
Yeah.
Um,
And I think, was the GCSF provided by
Yeah.
Gilead?
Yes.
So it wasn't an issue of, I
Well,
couldn't
getting
get
an
Was it
approval.
primary
Yeah.
profile? I don't think it was
It was-
It was
there was no
provided if
primary.
you
If you
decided
asked
to
for
use
it.
it.
Yeah, but it
And-
wasn't a primary prevention method.
Right.
Yeah.
Oh, okay. So
I had
they-
this trial open, I don't remember doing that.
They,
so.
they should have pushed them more, right? Because right now it's standard of care. I mean,
Yeah.
I'm putting all my patients on
Yeah,
primary.
of course,
Yeah.
yeah.
Right. All right, so again, we have 2 drugs, 2 TROP2 ADCs. We have an embarrassment of riches. They both seem to work. But the issue is that which one would you use? I mean, it sounds like people are going to use data from what I'm hearing around the table. Yeah.
I think so. I mean, there is some discussion to be had with the patient. I mean, there's always discussion to be had with the patient. But I think we can at least discuss both options and the AE profile. But ultimately, when making a recommendation, I think the efficacy, the AE profile, and just the schedule would really push
Yeah,
me towards.
Q3.
Yeah.
Does
that
even the
discussion
hint of
data.
ILD scare you?
I mean, I
What's-
do think that's part of that discussion, right,
Yeah.
that you
The
have with the
ILD.
patient, because sometimes it really does scare the patients
Well,
off.
have you ever
Yeah.
had have you ever extubated someone in an ICU? For,
Yes.
Well, thank God I'm not an ICU.
Well,
doc,
I
but
mean-
we've had
But you've gone to the ICU
ILD-related
to talk to
deaths,
the
of
family
course.
about
Yeah,
this,
yeah, yeah.
right?
We've
Yeah,
had
it's
So
ILD-related
I'll
deaths.
play devil's advocate a little bit, which is, we know SG pretty well, and the community knows it well. We
Right.
give, from primary prophylaxis, we make sure the diarrhea is managed, it's
Or
not.
dose reduction up
Dose
front.
reduction,
Yeah.
right.
And even messing with the schedule,
Sure,
right?
of course,
Q2 week
Q2
schedule,
weeks,
right?
yeah.
And where is that trial, by the way? Is
It's,
someone doing a
it's
Q2
still
trial
ongoing.
around?
Genentech, I mean, sorry,
Because I got an email from a
Gilead is still
community
doing
doc asking whether they could give it that way now.
I
So
mean, a
I'm
lot of
just
people do
curious.
give it.
That's
They do
funny
it
because I
anyways.
learned it from the
Real-world data
community.
now.
Yeah, really? Okay, fair enough.
Yeah.
All right.
But I will say, this new drug, is still a little unfamiliar, and it's a little fussy, right? You have to potentially get an ophthalmologist involved. You have to, do
You have to do
CT
scans of the chest.
of the
I don't think
chest.
we talk about that enough
Yeah.
with,
So those are
sometimes-
Yeah, the
barriers.
QT,
Yeah,
so what are you
screening,
gonna have to
screening.
do, so did everybody get, well, we're gonna get into that when we start talking about HER2 in a minute, but do they get scans?
Yeah.
The
Yeah.
Q6,
Every-
they
every
got the
6
Q6?
weeks.
Every 6 weeks.
just like in
which
HER2.
is-
No one's gonna do that.
No, no.
They're not going to do it, but which just, again, is that going to be a barrier not just for the patient, but also for the oncologist?
Yes,
Yeah,
I think
but-
familiarity,
Yeah.
But we don't do it with HER2.
we don't, we're
Not
supposed to, but
We
we're
aspire
supposed
to.
I
to.
mean, you can't really,
aspire,
logistically, you
aspire
can't
to.
do it.
The schedule doesn't help.
But,
Yeah.
yeah, I mean,
schedule is-
logistically, you can't do it with T-DXd, so you're not going to do it with this
Yeah.
either. So I
Yeah.
don't think that's a big differentiator. I think the optho issue is something that, again, if people aren't familiar with it, they're going to have to set up a relationship with an ophthalmologist.
But it's only with symptoms, right? Or is it before starting?
They
the
on
No,
trial?
you gotta
study
do-
they
No,
had.
You had to have it for asymptomatic disease, I think for how
It was
many
screening.
cycles?
Yeah.
So
And it's
the
screening.
label
Yeah,
says
yeah.
at initiation, and what AZ is saying is that at initiation means that they can get started, and
Yeah.
you kind of get it around.
Somewhere
the
around that time.
Yeah.
Okay.
So I'll tell you,
I'm
no, I
just saying
think the
it's
familiarity,
another-
no, VK, you're right, I think
Yeah.
the familiarity is gonna be a big deal. The other thing that's gonna be a big deal, I think, is that SG will get the label for PD-1L1 positive from ASCENT-04, right? So they'll get label expansion of both. This will only be expanded to PD-1L1 negative.
Mhm.
Is that gonna be a problem for people?
They'll get confused.
They'll get confused.
You know,
And
in the
then they
community,
do-
are they gonna
they
say,
do-
well, if I'm PD, basically, I'm just gonna give them SASI and just
I
add the
think that-
Pembro if the CPS is over 10.
Yeah, that's the thing to
You know?
grapple with, right? Because from a clinical workflow standpoint, you give everybody SASE first line, then you wait for the PDL1 status, and if it comes back positive, you
You
throw
have
on
your Sally
Pembro,
pass, right?
right? That's easy. But the counter to that is, I do think the first couple cycles of SASE, at least I tell patients that the first cycle
you
or
get
two or
diarrhea,
three
they
are
get
going to be
miserable, right?
rocky, right? Because
Yeah.
your schedule may be disrupted by the neutropenia, you're going to get the diarrhea and so forth. And so, again, I'm really swayed by the AE profile of Dato.
Yeah.
That's really compelling to me.
Or they may be early switches, if they start SASE as soon as their patient starts having trouble, instead of dose reducing, they may switch very quickly.
I think maybe what may happen is that the immediate progressors, people will go and say, look at Dato, because it's 0, it's not 6 months.
Yeah.
They'll get used to using it, and then they'll start using it for everything else. I think that's probably how this is gonna be adopted. That's my
And
guess.
I'm picturing, having the conversation with patients, and, when I first, even this morning, when I first started hearing the data, when they're back to back, you can say, hey, clearly I agree with Anna that these are both effective drugs in this situation. But when you actually think about it, when you're talking to a patient, purely looking at efficacy, I can't really come up with a reason why I would recommend SASE. You can explain, you can say, there's no survival benefit because of crossover. The difference in progression-free survival is because there's, the doublet and the non-proportional hazards of the, not that I was going to say that to a patient, but, you can explain
They're a
away.
statistician,
The patient
you
will
will,
lift, yeah. It's okay, no, it's
and
okay, a second.
the hazard ratio is,
The yield
is
professor.
0.6 percentage points different than it's pretty close to what Dato is. But you can explain all those things away, and still the data with Dato, there's a survival benefit. The hazard ratio is a little better, response rate's substantially better. all those
The
things.
side effect profile appears to be better.
I think many of us feel the side effect profile is a little better. So
But
it's just,
I think it's almost ethical, right? Like an ethical dilemma. You have to disclose to the patients what is going to be the
See,
superior
but for me,
option.
the ILD fear, I'm telling you, that's the ILD fear in the community is a big fear. It's a big, even though it's low,
Wait, what was
very
the
low.
ILD rate again?
it's 1%. It's
I think
no,
the
it's
medals-
nothing, but it doesn't matter. It's still the fear.
But then
of-
seven
you
deaths
tell
on
them, I mean,
Ascent
I have-
3. Yeah, right? So ILD versus 7 deaths on...
Yeah,
Oh, no, I
that's the
agree.
thing, like,
Yeah.
Gets
I don't think
tiflitis.
after
No, I'm
after
there.
the
I'm
event they
there.
care
I
about
get it.
how it happened. Like,
But
I feel, like, if we even see, despite all the confidence we've been using the drug for a long time, we see patients hospitalized after
Yeah.
the first cycle of SASI.
Yes.
We have had deaths, neutropenic deaths at Dana-Farber because
Yes.
of SASI. So it happens, and the fact that you see on the trial reflects the fact that it happens. And I think if we had to go through all the data, if we had the time during a visit to go through all the data and tell the patient, on this first-line drug, you have 3% chance of dying of neutropenia, I don't think the patient would choose that. Then there's many caveats. It was a global trial, patient didn't have prophylaxis as they should have, but it's still a lot. And it's not the first trial that showed this. The drug was withdrawn from urothelial cancer because they saw, I believe, 7 deaths or something. 7 deaths.
Again, without prophylaxis. That's
even,
what happened.
even with in HER2, you describe, you obviously need to tell those patients about pneumonitis or ILD, but you say, you can get some inflammation of your lungs. It's important that you let us know if you're having symptoms. But I don't think usually patients don't seize on that as being a deal breaker.
Honestly, I don't even know that I want to do the CT scans in this patient group with this drug. It's 1% is low enough that.
But these are triple negative patients. You're going to be doing CT scans.
No, you're
You
doing
do CTs every
3 weeks.
not every
Every
6
3
No,
weeks.
but you'll do them every
Every
9
3
weeks or
months,
every 12
not
weeks.
every 6, maybe every 12.
I agree.
Yeah.
So I don't know that this is going to be.
Though I will say
Yeah,
that
I
there was a
agree.
grade 5 event in TROPION-Breast02. There was one grade 5 event. So I think that's
1%.
Well, what
I mean,
was
not
it
even
for ILD?
1%.
What was the grade
for my LD.
What's
Yeah.
ILD?
So it's still a reason. And
That's-
it's in the footnotes,
Yeah.
but it's worth still, I think, doing scans.
It could be chance.
Chance. All right.
Yeah.
So I think that's good. So I think we have we've talked that out. All right. So then now let's switch gears for another half an hour, I guess, and talk about 2 trials that got presented at the same time. And I think had they not been presented at the same time, I think we would have had a better idea what it is.
Yeah.
The fact that they were presented back to back in the presidential session. We'll do DB05 first. You want to do that first? Let's do that one.
Okay. Do you
All right.
DBO?
No, actually, no. Let's not do DB05. Let's do DB11 first. I think that's the way to do it because that's the order they were presented. All right. So they did DB05, and so DB05. What do you think of the design? Are you unhappy there was no TCHP in it?
I mean,
So we're doing 11.
I had a conversation with some European colleagues yesterday, and they almost bullied me. Like, we're so afraid of anthracyclines. Like, we use anthracyclines left and right. It's like, yeah, but I mean, what is the rationale still, right? I mean,
Right.
And we're literally
Well, Sarah
decommissioning
really
it.
twisted the knife.
She did.
You know, she
I
really
noticed
twisted
that.
the
Yeah.
anthracycline knife
like-
some more.
Yes,
But,
you know.
I'm
Great.
telling you, like, they were taking it very personal. Like, we're not afraid of anthracyclines. We're curing people here. So, okay, that's I'm not fighting with you. But
All right.
it may
I
not be
mean-
necessary, right? You're overexposing
Yeah.
them to too
It's
much.
a
But
global
even with
study.
train 2 that was done in Europe, they still.
Yesterday they were saying no, anthracyclines left and right. Big believers.
Just train 2 was done in.
One thing that happens from an European, I've been practicing Europe, the thing is that for a long time, pertuzumab was not available in Europe. And so in the absence of pertuzumab, you throw everything you have. And if you have anthracyclines, you
Right.
throw I think it remained kind of as a fashion, something
Right.
that is done.
Right.
But I have to say, I was, a couple of years ago, I was reviewing a paper from MSK from real-world data, HER2 positive disease, and I realized anthracyclines, even at MSK, are utilized commonly. So I don't know, Shanu, what is the
You guys still
practice
use,
at
does anybody still
MSK?
use ACTHP?
Calling you up.
there are people who still use ACTHP. I mean, I think there are 2 camps, but this camp is getting smaller and smaller and smaller, just as more and more data is released. I mean, I think of it like, look, the gold standard was ACTHP, if we all remember, and
Right.
TCHP has kind of indirectly been proven to be as efficacious. There is no head-to-head.
Right.
So I don't think there is a problem with keeping this. Speaking as someone on the steering committee, there is no, and Ian, we talked
So you guys
about
are on the
this.
steering committee of
Not Ian, but I remember in the very beginning when we talked, I remember this was designed some time ago, and I think
Right.
we've definitely seen in recent years people switching more and more to TCHP. I would still use it in someone who has heterogeneous sort of a phenotype of breast cancer, right? So, and I think the rationale here, you've got replacing basically 4 of the ACA with 4 of the T-DXd. So there is some, I think, symmetry here, and it's a global trial.
And I think you gave, so that was
But,
the other question.
but that's an extremely relevant question today. How would the safety profile, if we assume TCHP is as efficacious as ACTHP, which we do, at the end of the day, then you still see a PCR advantage for T-DXd. What do we think about the safety profile?
Mm-hmm. At the other time, I would say also that this came at a moment where we were losing confidence in carbo. It was interesting to see at ASCO.
Yes, sure.
Well, no, I know, the Compass PCR.
So it's an interesting moment because we always believed that carbo was an important piece of this, and now we're realizing it may not be a critical piece. Like in the NeoCAR HP, same PAT-CR rate with 6 cycles of THP
Well, I
or
remember this is
TCHP.
going back into the ancient history, but TCHP, so I did TCH, Pegram did TCH with CIS, I did it with carbo in metastatic disease. And it's before the phase 3 trial came out. You know, it was BCRG 007, which we called the license to kill. Remember license to kill?
007.
We called it the license to kill. And so that we didn't have that
So
data.
wrong.
Had we had that data, had we had the TH versus TCH, I think it would have been TH. I don't think it would have been TCH in BCRG 006.
The curves
Just a
are
historical
perfectly
anomaly.
overlapping.
It was a
Perfectly
historical anomaly,
Well,
just to the way the trials came out, and people wanted to use carbo because it looked like it was better synergistic, and it wasn't.
Yeah.
You know, so that's kind of, so I can understand, because I would drop carbo all the time. I mean, I'm sure you guys did too. Quite a bit. It's like the first drug I would drop was TCHP.
Yeah. And now we have a large randomized trial suggesting certainly no impact on PCR. So
And I just wish, and now I understand, I think, Shanu, why people decided to do the T-DXd first, because you're replacing the
Yeah, in a way, you're kind of getting rid of 4 of the ACs with 4.
Because I would have done it the other way, right? You know, I would have given
Yeah.
THP first.
I
and
mean,
then
now
THC
just
second.
given the way the field is moving and everyone is sort of on board with THP and de-escalation to THP, and then, that would make sense.
And
yeah.
one other speculation I'll have is that T-DXd probably needed a little love from P as well for the solo arm.
Yeah.
You know, it should have probably.
Yeah,
been
whatever.
done.
Yeah, well, let's talk about that in a minute. We'll just go right to the let's go right to the PCR. I mean, I think that the one thing about this, these patients definitely were poorer risk than the typical patients you
Right.
see. That's the one thing that really struck me about it.
I mean, if you
by intention.
By intention.
By intention, right? I mean, you look at I think the PAT-CR for the control arm. I mean, I think maybe the closest study with similar like node positive stage 3 is like Christine, and even that has far fewer. So I think the PAT-CR of 56% is accurate for this population.
Mm-hmm.
This is a higher risk. 90% were node positive in this trial.
Well,
you know?
and 75% are ER
Yeah.
positive.
Are ER
So that's a
positive as
huge
well.
driver of
Yeah.
PCR rate, and
Yeah.
so
Right.
that's going to lower the overall.
Yeah.
Right. Although 52% in ER positive PCR with ACTHP is about right.
Yeah,
Yeah.
the control arm is as you would expect.
Probably
Yeah.
more the ER negative. I would have expected higher PCR rate. There's trials showing up to 80, 90%, and
I
here
know,
we
but
see
those have like
67.
largely like
Right.
But those are
T1
operable
tumors.
diseases.
Those are
so
smaller
less
diseases.
Very different
high-risk
populations.
patients.
Yeah.
That's why I'm saying, I think the closest population, I think, to this study is like maybe the Christine. And so I think these PAT-CR rates for the control arm are probably appropriate for this population.
No, when an RCB, I mean, when you include the
Which
RCB
makes
ones,
the-
90%
Yeah.
in the
Yeah.
ER, I mean, it's just about everybody.
Yeah,
Yeah.
that's,
You know?
that's phenomenal.
That is pretty phenomenal,
Yeah.
I have to admit.
Yeah.
That is phenomenal. So I guess, you know, and obviously there isn't a, do you care about the event-free survival difference? Do you think it's going to be real?
It
Well, it's
will
nice
be.
to see,
It's nice to see.
and it looks very
It's a little
nice.
slow.
Yes, it
The
does.
curves look nice.
Yeah.
Yeah, the curves are separating. So yeah, so we'll see. All right, so that's that. And then, what else do we want to talk about?
But I will say, she pointed out it was not powered for EFS.
Right,
Okay.
yes.
Right.
Yeah. And it's certainly not powered for EFS with 4.5%
Right.
event maturity.
Right.
Well, no,
But-
you know, the issue is that, well, doesn't the FDA want EFS?
They
Yeah.
have.
Yeah, they've,
So why would you not power for EFS?
well, this study was designed back, I mean, they designed it back, they
You're obviously good. You designed it. You
They
designed it.
had, no, but I mean, it was kind of following the model of pertuzumab. You have a neoadjuvant, and then you have your adjuvant study, the
registrational study.
Destiny-5, and you
Right.
can use those together. And I think that's the plan at this point.
Fair enough. Do you think the FDA will approve this? I know we're being recorded. I don't know if we're allowed to say this, but
I think there's
without
challenges
EFS,
in their
without
interpretation
EFS?
because they're very different populations. Like one is selected for residual disease, the other one is all comer. So I think there's challenges, but I think the data are too compelling not to approve.
because the
So I would
FDA,
predict
man, they remember Keynote 522. They were
Yeah.
really hardcore.
So the FDA
It misses by 1/1000th of a p-value, and they didn't approve it.
But
Right,
the
but-
NCCN is definitely going to
Oh, NCCN will approve it, but will the
Yeah.
FDA?
Yeah.
kind of.
I mean, I think the Keynote is a different situation because we had no data on immunotherapy in the early disease setting at that
Yeah.
point. You know, we have so much data on HER2 where, you know, PCRs in general have been correlating with long-term outcome.
I hope they approve it. I think
Yeah.
it's
I
a
hope
great
so, too.
option. I
Yeah.
think it's
Yeah,
putting
well-
my clinician's hat on. I'd love to have this.
Yeah.
It
Yeah.
was less toxic than ACTHP, and we can debate how would it compare to THP, right?
Right.
But
Now, are you okay with only 50% of the patients in both arms getting TDM1 who didn't have a PCR?
that
You're
was
okay with that?
very surprising
That
to
was
see,
surprising.
right?
Yeah, that was
It
surprising.
may have an impact on the event-free survival
right.
at the end of the day, but yeah, that was really surprising. But
Okay.
again, global trials
Yeah.
and access is.
Yep.
And I think the good thing also was there was not that much pneumonitis, right? 5% pneumonitis rate.
Yeah. I guess it would be nice to see sensitivity analysis in the adjuvant TDM1 population,
Mhm.
if it ever is done.
Yeah.
Would be reassuring.
Okay.
Actually, the 5% pneumonitis was actually in the
In the control,
control arm.
Isn't
Yeah.
that weird?
Sorry.
5%
Well-
pneumonitis in the control arm?
Well, it's because we're not used to doing CAT
Yes.
scans in
Yes,
these patients.
exactly.
So when you do CAT scans, you realize that there was a bunch of low-grade.
Yeah.
Neil, we
Well,
did
Well, there
Yeah.
was
a
grade
study
5
where we
pneumonitis,
saw a lot
there was
of
death from
in
pneumonitis in
AC.
Yeah.
both arms.
Yeah. I mean, this is what concerns me too. Is this is the curative setting, right? And
Yeah.
you know, we've learned to not be so aggressive about checking blood counts sometimes, so that we're not compromising the dose delivery, right? And so, are we looking for ILD too hard in the curative setting? And I mean, you could make the flip argument: this is the curative setting, and you want to make sure you're screening for ILD.
Right.
But I think the counter argument to that is, are we compromising dose delivery?
Yes.
Yeah.
Because don't you have to stop? Like what happened in this
Yes.
trial? So if you saw, because the radiologists they're so tuned to this now, you don't ever get a scan that says, that doesn't say could not be
Yeah.
ILD,
Right.
could be pneumonitis.
Right.
Clinical correlation is recommended.
Clinical correlation record could be pneumonitis. I mean, the radiologists are going crazy with this.
But I think that's the major problem with the TDXd alone arm, because among
Yeah,
the problems that led
yeah,
to the
let's talk about that for a minute. What do you think of that? Is that just kind of bothersome?
I think it's ILD. I think that's
No, it
I-
was not at all, actually. They stopped that arm early because the PAT-CR rate was low.
It was
It
low.
was
40
not
something,
ILD.
right? 40
If you look at
It
the
was less than
ILD,
the control.
it was
It was
zero.
13
There was
percentage
no
points less
high-grade
than that.
ILD.
Which again
But-
speaks of the lack of pertuzumab, right? I mean,
I think
clearly.
so.
But
pertuzumab-
You think it was the
was there
pertuzumab?
more of a delay to
Yeah.
surgery in the
Yeah,
monotherapy
yeah, and
arm?
there was, and
Yeah.
that was kind of a sticking point because there was a strict window to get people to surgery,
Right.
and a lot of us were like, so what if somebody's a little bit late? But that would.
But do
that was,
you think the pneumonitis screening could have contributed to that delay?
I don't know. I think that's a good point to
Mm.
add. But if you look at the pneumonitis rates, I mean, it wasn't so bad on the.
Well, and it's only 4
monotherapy.
doses, right? Like we know.
Yeah.
You know,
You
you,
s-
You
need
need
to
to
do
do
it
it
more
more
than
than
that,
4.
yeah.
No, and the fatigue
Yeah.
wasn't that bad too for the same reason,
right.
right? Fatigue wasn't
Yeah.
too bad because only 4 doses.
Yeah.
So
No,
again,
that was a real strength of the 4 doses.
had this been by itself, we'd be sitting here going, this is the new standard of care for high-risk disease, right? Would people
Yeah.
agree?
Yeah.
Yes.
Yeah.
Yeah.
I think I would have.
Don't even talk about 05.
I would have
Just
won that.
Keep
not
that
me.
in your mind for a
Not me. Without adjuvant data, I think I would have wanted to see more EFS data.
So without adjuvant data, you would have said you would not have approved this. You would not have used this in your practice yet for high-risk disease.
I feel like it's an important piece of understanding what is the impact of the drug in this setting.
Yeah.
And I think, just like for the NeoCAR HP, for CompaSSR PCR, we think that PCR data are relevant, but EFS is critical. And I think in this case it's the same. And having DB05, I think it's so reassuring that you have a long-term
But no, but
benefit.
keep DB05 out of it for now. Just assume it was never presented. I just wanted to kind of, because DB05 changes everything a little bit.
I mean, in a lot allowed
And-
inflammatory breast cancer, so if you have an inflammatory breast cancer that's HER2 positive, wouldn't you love to have this option?
Of course.
Yeah.
No, I
Yeah.
agree. But
No,
without
but
EFS,
I
Paul was
think-
saying without EFS.
Paolo's perspective is what the FDA shares. I think like you kind of need to show nowadays, just given what we know about PCR as an
Longer
endpoint,
benefit, longer time
they're
benefit.
going to want to see, and that's where DB05 is
Exactly.
going to be
It's
very
critical.
critical.
And I think it's you're helped by the fact that it's not just T-DXd. I think if you had the
Right.
T-DXd alone arm,
Yeah.
you can imagine that you really, that's particularly you'd want long-term data. But here, you're giving 4 cycles of THP, and I think
Yeah,
a lot of us are
that's-
comfortable with 4
yeah,
cycles of THP, having a PCR and say, hey, we're good. Here, we're doing that, and we're getting.
So would you
Yeah.
limit this to the patients in the trial, the high risk? Would you give this to operable disease from T2 and 0, some because of a 3 centimeter ER negative HER2 positive tumor? Would you give this regimen to them?
I would not.
I don't think so.
You probably won't be able to.
You don't think it's going to be in the label? It won't be labeled?
I think we'll
Or the
get.
NCCN won't allow it for that?
I mean, what's
Probably
going to
not.
happen is a trial specifically for them in the adjuvant setting, I suspect, right? Like, yeah.
So I will say we are learning more and more that biology is more relevant than anatomical extent in
Correct.
this setting, and so I really wish we had a good way to screen patients that get THP and are not gonna have
Well, you
a
think
complete
HER2-DX
response.
is going to be that screen?
HER2-DX,
I
ctDNA,
think-
MRI, something that helps you.
mammoprint
Well,
assay
we
does-
also,
We'll talk
Yeah.
Mayoprint definitely.
I mean, the other, I agree with you. It'd be nice to do this in a staged approach, or have some way of deciding who needs more and who needs less. But one approach, I think, which is one of the things that Sarah Talini had mentioned, is give THP first, and if their cancer melts away, you can take them to surgery because if they still have unexpected residual disease, you can give them T-DXd out back. And if they're not having a great response by imaging and palpation after 4 cycles, then you give the T-DXd.
So that begs the question. So then you give that, so you give your 4,
Right.
you give your 4 DXDs, and they still have residual disease.
Yeah.
What do you give them then?
Yeah.
TDM1.
TDM1.
Yeah.
So you give them TDM1?
TDM1,
Yeah.
maybe TDM1 to catnip.
Yeah.
Yeah,
Yeah,
TDM1 to catnip. That's not
That's not that far away.
That's not bad. I never thought of that.
I would
TDM2
do that.
catnip, I like that. The compass RD.
You need
regimen,
a
I
different
like that.
mechanism in there in that setting, I would
Yeah.
argue. So.
Yeah.
And if there's a lot of burden, you may think of anthracyclines.
I mean,
Yeah.
you have-
Not that we love them, but if you have a lot of burden, you may want to
You
use
have a
them.
TKI and a different payload, truly, right?
Yeah.
Yeah.
So,
Yeah.
Yeah.
It could work.
Yeah.
All right, so now let's go to DB05, which I think has thrown a wrench into the whole thing to a degree.
Yeah.
Had we
Yeah.
not had
We
DB05,
hate all
I
those
think
effective
everybody would have been
therapies.
on the same page. But now we got DB05. Again, this is one I think a lot of us have been waiting for a long time. This is really,
Yeah.
this one and Compass RD are the 2 big ones,
Yeah.
I think, really.
Yeah.
And I think
Yeah, curing breast cancer is a good thing.
It's a good
I think we're
I
pretty
agree.
excited
Good
about
goal.
it.
And I think that, was this unexpected, the result?
No.
No.
No. I think we all expected DXd.
The most
to be
expected
better.
data.
After the Cinevest 3, right?
Yeah.
We know that.
But-
Yeah, but the
DXd is
question
gonna-
is,
but
but it
TDM1.
didn't really work in the neoadjuvant setting, though.
That was in
single
HER2
agent.
negative cancers.
Yeah, it was
This is the
HER2 low.
first data we have in HER2
HER2
positive.
positive.
In any early breast cancer, HER2 positive. This is the first T-DXd data we have. That's what was so
Yeah.
exciting about it.
No, I agree. And the trial design's it's a typical NSABP trial, It's
Yeah.
very tight design. I mean, I think that do you have any problems with the design of this?
the numbers are large, which I appreciated.
Yeah.
I
I'd
would say
still-
one thing that not many realize is that this is a very, very high risk population. It's not any residual
Yeah.
disease.
Correct.
This is node positive residual disease or inoperable at baseline.
Yeah.
And
Right.
I've been struggling to think of how many patients we see with these features, and I would love to hear your opinions. How many of your residual disease patients are node positive?
I know, because I'll tell you, I tried putting someone on this trial forgetting that you needed node positive, and I got rejected like 5 times.
Yeah.
I kept doing it. I kept forgetting.
I can think of several in the last one. So.
It's not for all the patients. I think
Right.
that we're going to have 2 standards of care in the adjuvant residual disease setting, T-DXd and TDM1.
So operable disease comes in as residual disease. So you give them THP times 4. They have residual disease. Will you give them will you give them TDM1?
If it's
Yeah.
node negative,
If it's
yes.
not-
For node negative.
Yes.
You give them TDM1?
That's silent.
You can do that. You're not going to give them DXd?
I guess the
I'd
only
like to give
situation in which I
TDXd.
would
like,
be
yeah, I would like that. That's my one gripe about the
Yeah.
design is I wished that it paralleled Catherine a little better.
Yeah.
Mainly because I want
On
would
the
want-
low risk end.
on the low risk.
Yeah.
Yeah,
Yeah.
mainly because I would want to offer this to more.
I mean, I think that
patients.
probably the thinking was that the risk benefit is so different.
Yeah.
With the ILD
And the
and-
ILD
Yeah.
risk, so
I think
they
that's
were really
fair, the
picking
ILD
high
risk.
risk.
I think if they would have used fewer cycles of
Yes.
T-DXd,
Yeah.
That's
then-
my beef
then
with the
they-
trial.
Then
is-
it would have
yeah.
been fine to do lesser, lower risk patients.
Yeah.
But I think the way
Right,
they did it
right.
was, they knew
Yeah,
that they were
appropriate.
using an aggressive
It would have been
adjuvant regimen.
criticized, I think, if
Have they done lower cycles?
Yeah. No, you
Or
mean lower
lower
risk
risk.
people.
Lower risk,
Risk
yeah.
patients,
Putting
yeah.
them at excess risk of ILD.
Yeah.
They
Some of them with
picked
curable
out
disease.
those patients who get 60%, 70% invasive disease-free survival with
Yeah.
TDM1.
Right.
Yeah.
and that's who they put in this
Yeah.
trial.
No,
Yeah.
I agree.
Appropriately.
Appropriately.
Yeah.
Well, and also if you did go with those patients, you would need a lot more patients and needs to
Yeah.
go up because you're,
Yeah.
Yeah, to
you're
follow
pushing
up
your
on the
luck.
difference.
I
You're
agree.
pushing your luck.
Yeah.
I was pleasantly surprised 72% got through 14 cycles.
Yeah.
I was
Yeah.
surprised.
70%, and I think the real
Yeah.
interesting question is going to be is how the 32 or 28%
Yeah.
who didn't,
Yes.
how did they do?
We'll see.
Their
And
mean
I-
cycle length and how did they do? When is it
Yeah.
like a mean of 8 cycles does the same?
Yeah.
Right. That's the question I think that we're going to have to answer.
Right.
Well, that's when you need
For
to incorporate
research,
potentially
for
molecular
research.
markers,
So,
circulating tumor
I mean, the way I would take
cells.
it pragmatically is that would be our intent is to give the full, but we're not going to lose sleep if they
Yeah.
get 9.
Right.
You know,
Absolutely.
Did we ever see this data from Catherine? I'm not aware of the data
Of
of
the
the
people
patient
who
that did not
dropped,
complete.
yeah.
What were their
I
outcomes?
think most of the patients in Catherine surprisingly did.
No, there was a lot.
In
I think it was
attempt, it was
70%,
not.
like
In
this,
attempt, about
very-
a quarter of the patients couldn't make
very
it.
similar to this.
76% got
70%.
through 14 in this cycle
Yeah.
as
Yeah.
well.
It was about 70.
70%
So
also in
70%
Catherine.
in
70 as
Catherine.
well.
So
Okay, it's
30%.
the
Yeah,
same.
you know, that's what was so surprising,
Yeah.
because it was the same
Yeah, I
number
was-
with
I couldn't
TDM1,
believe
which
it.
we all think of as
Yeah.
very easy.
What's
Yeah.
interesting is with Catherine, if they couldn't finish TDM1, they got Herceptin. If they couldn't finish T-DXd here, I think the majority of the patients got TDM1.
They did? Were you
Oh,
allowed to
That's
get
what
Was
TDM1?
it
I
allowed?
heard.
I missed
I
it.
mean, I
I don't remember. I just don't know. I
weird.
thought you had to go to Herceptin.
Yeah,
but that's
I'm
interesting.
not sure about.
The American, I think the American patients, I don't know if someone in
Got
AZ can
TDM1.
pipe it. I think a lot
Well,
of
which
them
is the
got
standard of care, right? That
TDM1.
kind of makes
Yeah.
sense. Maybe the
That
rest
makes
of the
sense.
world was
Yeah.
just trastuzumab.
I
then.
think in most of the US sites, they would have finished with TDM1.
Yeah.
Yeah. No, I mean, 92.3%, 3-year EFS, I mean, that's, in very high-risk
Amazing.
disease, that's pretty,
Yeah.
that's
It's
substantial.
amazing.
Yeah,
Yeah.
that's
You
really
know,
Yeah,
nice.
that to me, with the hazard
You're
ratio
kind of putting them
0.47,
into the
that's
PAP
pretty
CR,
good
what
stuff.
Also,
you might
it's
a
expect
drop
with
in-
cancer patients.
CNS Mets is a first-sighted disease.
Do you believe that?
I'm going to
Do we
believe it.
believe it?
What?
Do
Do we
believe-
believe
The
what?
fewer
CNS
CNS
finding.
Mets in the.
I'm going to believe it.
It makes sense, but the difference is small.
Yeah,
And
I thought the
honestly-
difference would be bigger, actually.
Yeah.
to be
Can I
honest.
tell you, CNS was not rigorously, it's not like
Yeah,
everyone
right.
had a
That's the thing.
baseline, you don't
Sure.
know.
Oh,
This
that's
is
right.
just
Yeah,
whatever
yeah.
they're picking up,
Yeah.
so
Yeah.
we don't
Yeah.
really know.
But we think we believe the CNS data, but we're not sure. We need to
I
wait
don't know
for
if it's
longer follow-up.
preventative or not, that'll
Well, I
be
mean, but
interesting.
DB12 was
Yeah,
quite
but-
positive,
but
right?
that's
So you
not
have to-
that's not prevention, though.
Yeah.
That's
No.
treatment.
That's treatment.
No, but I mean
Yeah.
the fact that you have very high penetration of CNS, and we have all seen very good responses with
But
TDXd.
that's still treating, and
Yeah.
and the CNS is, probably not
Prevention.
fully
Do we think
intact.
that-
Well, that's
I
it.
mean,
I mean,
TDM1 works in the
how do you
brain.
believe? Do you believe in the disrupted blood-brain barrier
Well,
hypothesis?
we do
or
know
not?
that TDM1 is fairly effective. It's not 60%
It's
intracranial
30.
response, but it's,
30-ish.
with Camilla, it was,
Yeah.
30, 40?
30, 40.
yeah. So I mean, it still has activity there.
Right.
And yet, it didn't do anything in
Yeah.
Catherine. So I think the fact that
I mean,
you see some benefit here
To
is
Ian's
impressive.
point, it's the disrupted blood-brain barrier, and then there's the disrupted blood-brain met barrier.
Well, no,
right?
that's the point.
Yeah,
Don't you
so
have to
they're
have a?
different.
I think there has to be a certain size of the Met for it to work.
Right, I mean, I think
It has to be.
that's.
What that size is, I don't think we know,
Yeah.
right?
So you don't buy CNS prevention then?
With
this
these big
drugs,
molecules,
yeah.
no. I don't. I mean, well, I guess I don't know.
Well,
Obviously, if this is
yeah.
true, you have to.
Or,
Right?
I mean, I guess it's possible that they had there's
Mets
people
and-
had Mets at
Yeah.
baseline.
That
and-
they didn't
and-
know about.
Yeah.
Like
Yeah,
they had
they
like
didn't
a
know.
0.5 millimeter Met
Yeah.
that people were just blowing off.
Yeah.
Or something.
Yeah.
They thought it was a vessel,
But I wonder if it has to do with how a half-life and how long these compounds linger in the CNS, because we saw that exploratory analysis in HER2 Climb where there was a preventative effect. It was very exploratory.
Yeah.
Well, no, but that's a small molecule that goes through the CNS.
Yeah.
It's a small
So-
TKI.
But if we
that's
assume
okay.
that both drugs penetrate the CNS, right? Why would you get more of a prevention effect with one over the other?
Yeah.
Well, albumin-bound topo-1 isomerase inhibitor probably doesn't cross the normal CNS like tucatinib would, right? Tucatinib will cross.
So you think there's just a
I
higher
just think
concentration of
It's
drug
not just
there?
concentration. The
Size.
brain Mets vasculature is just very different, right? It's as crappy and leaky as any other tumor vasculature, so
I think
we'll
we
probably
can
get
learn a
drugs
lot
across.
from stroke. I think we need to learn from our stroke colleagues.
So,
a
but
lot.
do we
I've been
do?
trying to get some
Well,
young
once we
fellow
get the
to learn
adjuvant
to
to
do
cabinet
this, to
data,
deal
we'll
with it.
answer this
Yeah.
question.
Yeah,
Do we
exactly.
do baseline?
Well, the only
brain
prevention
metabolism?
data we have
Yeah.
is extenet, right?
So
And
they
it's
probably
a
have
super
that point.
subset analysis.
Right.
Yeah.
But it did show a benefit.
Right.
But we
It was the
believe
only-
Compass RD will work.
Wow.
Well, what about what is it called? What's the one?
Astefania,
The new
Atezo,
one that just was announced that's going to be shown at San Antonio.
the
prevention
HER2
the
Climb-05.
prevention DB was
Oh.
it
HER2
TB?
climb of
You mean
5.
HER2 climb
HER2
of 5,
5, that's
yeah.
prevention
Maintenance.
in metastatic
That's
disease.
That's
right?
maintenance.
And it worked.
That's maintenance.
It's a
Well, we
positive
don't,
trial.
it's
It's
a
a positive
positive
trial.
trial.
Did it prevent
Maintenance
brain mets
We don't
in
know.
a press
That
release?
we
We
don't
don't
know.
know.
It's
The
in
thing is that
maintenance.
also HER2 Climb-02 was a positive trial, but by
Yeah.
just a
Yeah,
couple of
it's a
months,
skosh.
and it
Right.
didn't impact practice. So I feel I was burned by HER2 Climb-02. I really want to see the
We
data
really
to
wanna see the
understand the
data
impact
for-
of
I mean,
tucatinib.
I think the hope is, for this hypothesis, is that HER2 Climb-05 will show a decrease in brain mets.
They
That'll
were-
be what's driving
I think
the
it's,
event rate.
it's the Compass residual disease. I think that's a secondary endpoint,
Yeah.
looking
Yeah.
at brain
Brain
mets.
mets,
But
right.
HER2
That'll be really useful.
5,
Yeah.
they did have brain met screening when they went into maintenance phase. This trial doesn't have
Yeah.
brain met
Right,
screening.
right.
So
No,
there are
no.
probably some baseline brain mets in some of these
That are
patients.
being treated.
Right,
Right,
right.
right.
It's totally anecdotal, but
Yeah.
we had a patient on DB11 that got 8 cycles of T-DXd, had PAT-CR, and then had a brain met as a first event.
We had one too.
Well, that's
Right.
going to happen. You're never saying
I
it's
know it's
zero.
gonna, I said it
Zero.
as an anecdote.
Yeah.
But now we have
Yeah.
2. Oh my God, we've got
But not to get too
Case series here.
tangential, but HER2 Climb-05 better show a CNS benefit because I don't
Yeah.
consider that to be maintenance anymore
No.
when you're
No,
throwing
you're right.
tucatinib in the
That's
mix.
correct. I
right?
agree.
They were
Right.
struggling
That's
to get
going to
that
predict.
public
I
here.
think.
Compass RD.
I think that's going to
Both
predict
HER2
Compass
Climb-05
RD.
yeah.
I think
Possibly.
TB. We're going off topic.
Yeah.
But I think that's going to predict. I think HER2 Climb-05 is going to predict Compass RD. And if it does prevent brain mets, then likely Compass RD is going to be positive.
Yeah.
Yeah.
And we kind of think it's going to be positive based on the sub analysis of extenet.
Yes.
And I suspect that's what's going to happen.
Mhm.
We'll see. We'll find out in about a month and a half. Is anybody probably at this room is probably an investigator on 05?
I had 05.
So you did. So you're going to know the
I
data.
put patients, well, I don't know if I'm going to know the data, but I'm going to put patients.
You're an investigator. They're going to show you the slides. All right. Fair enough. All right. So I think anything else you want to talk about this before
Well, we
move
haven't
on?
resolved, Adam. Are we going to use it pre or post?
Well, that's the question. So let's ask the question.
I was
mean,
waiting for Sarah to answer that. I don't think I got a
know,
clear answer.
right.
No, Sarah did not answer it. She came up with this really
Well, she gave this
complicated
a
kind of
Yeah,
like
the algorithm.
15 things on the
Yeah.
algorithm. It's
Yeah,
kind of trying to
I
follow
liked
it.
it. I thought it was a
It was a great
very
discussion.
well thought out approach.
I mean, I
Yeah.
think
For you, but for our community
Yeah,
colleagues, yeah.
fair.
Well,
fair.
So, I guess even if you're, even if you don't want to be trying to have a Goldilocks approach and do just the right amount for each person, I still, for a relatively high-risk person, feel that using it preoperatively, knowing that, especially if you're ER negative, you've got an 80% pass CR rate.
like a 90% with RCB1 on top.
Yeah, the RCB1 is different. I mean, in HER2 positive disease, RCB1 still has some negative
Slightly,
prognostic
yeah.
effect, and you're still going to, I guess,
But still, it's 83%.
80% is a pretty good odds with not a lot of downside,
Yeah.
and then you don't have to have 14 cycles of
You
You know what?
TDX.
That's exactly how I said it. I don't see the downside for patients after looking at DB11.
And I do
right?
like
The only
what you
downside
said.
is you don't know what to do afterwards if they have residual disease.
Well, I
Well, but
That's
you
the
don't know what to
problem.
do afterwards if you're,
Yeah.
I mean, yeah, you're going to give T-DXd to those patients who you didn't give it before, but that doesn't change the biology of their cancer, that all of
Yeah.
a sudden it's
Okay.
going to work great in the patient who it didn't work great for neoadjuvantly if you would have done it that way.
But would
It's-
you
just don't know
swap
that, you don't know who those patients are.
Would you swap THP with T-DXd though? I'm inclined
Yeah.
to do this.
The sequence.
Yeah.
you
The
mean,
sequence.
I am
side.
too.
Yeah.
I like
I
that
think it makes
suggestion.
sense.
I think
Yeah.
you're going to see IITs with that.
Yeah.
That's what the community is
Javier
going to do.
Pertez
It.
has got an IIT.
I think the community is going to flip it. I think the community is going to use this for operable disease, for less high-risk disease. I think that's what's going to happen. They're going to use it off of whether the label is going to be.
I don't know.
You don't think so?
They're scared of T-DXd as well, I feel like.
You think so?
I
But they're
guess
gonna see that
the
80%
question
was-
I wanted to get answered is, if you do it neoadjuvant and you still have residual disease, do you feel like it wasn't enough TDXd?
Right,
right.
Yeah, because
Right.
that's more cycles, right?
It's an
There
open
you go.
question.
That's the question.
Yeah.
That's really the hard
So
one.
then you're exposing them to 18 doses.
I wouldn't
Of
probably
DXd.
give, I don't know that
But
you'd
That's
get
not
through
generous.
14 more.
that is a
but-
perfect scenario, though,
Yeah.
to go to TDM1 and to catnip.
Yeah,
if that is
exactly.
positive
Maybe
trial.
you pull your
Yeah.
14 half
Yeah.
and half, you split it.
Would you feel comfortable using TDM1 alone in the current landscape in that setting?
I mean, it kind of stinks after you see this, but
Right.
this is a super high-risk population.
Yeah.
So, I mean, when you look at the node negative, like path node negative TDM1, they do well. They do
Yeah.
88,
Yeah.
89% disease-free survivals.
Yeah.
7 years, am I quoting
Yeah,
it right?
7 years.
Yeah.
So,
But,
But
it's
at the
interesting to
same
see what the
time,
FDA
with
does.
no, I know,
residual
my
disease
heart
close
is
to
out
the
there,
three-year
yeah.
EFS.
yeah.
What are they going to do without 3-year EFS? Are they going to approve it? Are they just going to label it post-neoadjuvant? And call it, in other words, use DB11 as supportive data for DB05?
Well,
You
And
meant
just
the
give
other
you the
way around.
DB05
The
label.
other way
That's
around.
it, and
Yeah.
that's all they're going to give you.
do you need supported? Like
Yeah,
I feel
yeah,
DB05 is
doesn't
just
Got
need-
survival.
doesn't
need
need
supportive
support.
data.
I
It's
know,
more the
but you know
opposite.
what I mean, the totality, you know how
Yeah,
they do
yeah,
this,
yeah,
the
yeah.
totality of the data.
Yeah.
That's going to be interesting because, so if we don't get it, then obviously we're just going to give it post, right?
Mhm.
For 14. I don't know what they're going to do without EFS. I don't know.
Yeah.
You think they're going to approve this?
Well, they
really
did the
hope
trial. I mean,
what, like they,
AZ did the trial. I'm sure
Which
they.
I'm
I'm
which
sure
the
they
FDA
had.
Right,
agreed
what's the
to.
answer?
The FDA agreed to the
And
design.
you know, 05 is
yes, I
05
think
is-
because you have both, like
Yeah, both.
we've done with pertuzumab,
Right.
I suspect they will accept both
Yeah, I
together.
mean, 05 is a
Yeah.
home run. They couldn't
Right.
have expected anything better than that.
Yeah.
Right.
And 11 looks
Great.
pretty damn good.
Yeah, 11
So,
does
you
look
know,
great.
I
And
think-
also, for most patients, I think it's not a choice to give it before or after because DB11 is a very inclusive trial. There's a broad population of patients with T2 and 1, T2 and 2, etc. DB05 is much more restricted. So there's many patients that will have T3 and 0 residual disease. They
Right.
don't qualify for
Right.
DB05. And so it's not that we always get the choice of giving it before or after. For most patients, it's only before.
So if someone
and
has
I don't-
T3 residual disease, would you give them DXd? I probably would.
I would.
We
I
try
would
to
be
get
tempted
it, try to get
if
it.
we
Well,
could get
off the
it,
label,
yeah.
I probably would.
At T3,
Because, I mean, in addition to T3, is it RCB0, I mean, RCB1 T3, or is it RCB3 T3, right? Like, you know, is there a lot, is the cancer still packed with cells, right? Like,
And there is another
viable.
situation that I'm keeping on thinking, the one where you have HER2 positive disease that turns HER2 negative as residual disease.
Yeah, what do you do with that?
So we have the subanalysis, tiny subanalysis of Catherine suggesting a benefit with TDM1, but I struggle to believe it. And we know that T-DXd works so well in that population, and so I would be so tempted to use
You
it.
know, one of the things in going back and thinking about DB11, you know, we restricted it to like centrally confirmed, and so it was all IHC3 plus like 89%. If you look at the tiny subgroup, the 2+ fish really do well with T-DXd. Those are the patients who really should get it, I think, in the neoadjuvant setting. You know, we see them all the time, like the fish is
With the fish is
2.06
2.2.
or something, and you're like, oh
And it's going
God.
to be really neat to see. I'm sure they're going to have the data, the heterogeneous patients. So the ones that start, that turn negative.
Yeah, it was just,
Do they
Yeah.
really, are they driving a lot of the EFS
Yeah.
benefit?
Yeah, I'd like to see a repeat of the analysis you guys did in
With this,
DB05. Yeah.
with 05.
With
But
The one thing missing in the subgroup analysis is the 3+ versus 2+. That is not present and
Yeah,
would
I
be
was-
nice to see.
DB05.
They'll
I was
have that.
surprised
Will you
with
guys
that,
have
yeah.
that, AZ?
We're going to be presenting more at SABCS, so I don't know if that's specifically.
Why write one paper when you can get 5?
That's 5
Why one more
investigators, you make
presentation
happy,
when you get
BK, come
That's
on.
right.
If I get the paper as a reviewer, I'm going to ask for that. Are you sure?
Okay, cool. Well, no, this was so new, you can't have simultaneous publication. It was just so quick,
Yeah.
you know? All right, cool. I think we've exhausted this. Anything else you want to talk about?
What a cool ESMO. What an amazing
Yeah.
ESMO.
Yeah.
This is a
breast
pretty good
it
one. For
was,
breast
yeah.
cancer,
Yeah.
and
Well, it's
that's it.
getting
What else is
breast
left for
heavy
breast
everywhere.
and ESMO? Anything else? Or
Many
we're done?
orals tomorrow.
Yeah.
You
And
get
I'm also proud
PRO
of this
analysis of Serena 6.
Yeah.
And I'm also proud of this group of not talking over each other. Like,
For the most part.
yeah, very because the European version that would have happened.
Sorry if I need some time.
Well, they all would have been mad if they weren't getting
It's the European
anthracycline. No, again, Sarah really twisting it. That was
she was really
twisting the
killing the
anthracycline.
anthracycline.
Yeah. Are we hopefully
Well,
we're
the
off-
message
off-
was received, I'm telling you. I almost got bullied years
Wait,
ago.
I do have a quick question. Are we going to get quality of life data, PRO data in
Yes,
these?
I know for
Let's-
DB11, we submitted it to
Yeah?
SABC.
Okay.
yeah.
Okay, good.
And
Yeah,
11, I
great.
mean, how different is it going to be? You know?
Yeah.
Yeah.
Because you just don't take it long
You know,
enough to get
the
fatigue.
only thing we didn't talk about was the hair loss with T-DXd. You know, the 14 cycles, I
Yeah.
mean, those poor patients are so beat up, right? And at least they're growing their hair back. They may not grow their hair back
And
with
scalp
TDXd.
cooling doesn't work
Yeah, it
as well with
doesn't work, yeah.
T-DXd.
That's a good point.
Have people tried it with the ADCs?
Tried it.
Yes,
yeah.
there's
It
a
doesn't
trial.
work, right?
There's
We had a trial.
in
You guys
Dana-Farber.
have a
We had a trial at
And it didn't work, didn't
Dana-Farber.
work.
20
It do-
patients with scalp cooling, 20 patients without, same level of
So same level of
alopecia,
hair loss?
50%.
Yeah, okay.
But it's tiny.
It
sample
definitely
sizes.
doesn't work with sacituzumab. It works some of the time with T-DXd. And some people don't lose their hair with T-DXd.
That's true.
Right,
yeah.
that's true. Good. All right, guys,
No, not
thanks. This is
permanent.
great.
Oh, okay,
They-
just
they
well.
don't
Okay,
allocate
all right,
that.
excellent. That makes sense.